Now we are going to discuss two important acute complications of diabetes. Two important acute complications. One being your diabetic ketoacidosis, diabetic ketoacidosis, and the second one, hyperglycemic hyperosmolar state, which is abbreviated as HHS. Okay, and this one is also referred to as the HONK. What is this HONK? Hyperosmolar non-ketotic coma. Okay, so these two are two acute complications of diabetes that we are going to learn. In fact, they are two emergencies that has to be managed. And again, this is a good knowledge of this is important because this is one of the common cases. Your diabetic ketoacidosis as well as your HHS are two common cases that you would manage in your emergency department. Okay. All right. So let us move ahead and deal with these two conditions. Okay. Why does this occur? And is there any similarity between these two conditions and what are the differences? See, this diabetic ketoacidosis, DKA, okay, diabetic ketoacidosis. This is something that is more commonly seen in your type 1 diabetes mellitus. Does that mean type 2 doesn't develop DKA? No, but the chance of development of DKA is more for your type 1 diabetes mellitus. Okay, and then coming to your HHS, this is an entity that you more commonly would associate with your type 2 diabetes mellitus. Type 2 diabetes mellitus. Okay. So what we are going to do is that first we will begin with the pathogenesis. Okay, pathogenesis. And in the pathogenesis part, we will discuss both DKA and HHS together, and so that we get a good comparison between the reason why these two entities develop. Then we will discuss diabetic ketoacidosis and then we will discuss HHS separately. Okay. All right. So let's first see the pathogenesis of this condition. Coming to the pathogenesis, I'll just take your attention to a flow chart. So this is a flow chart that shows the pathogenesis of both your DKA as well as HHS. Okay. So both shown in a single chart means there are certain similarities, but again with certain dissimilarities. Now what happens is that you see here, there are three factors. One is your absolute insulin deficiency, counter regulatory hormones, and a relative insulin deficiency. So in case of your HHS, these two factors, that is your relative insulin deficiency, because it most commonly occurs in your type 2 diabetes mellitus, and the increased counter regulatory hormones, these are playing an important role in HHS. All right. Whereas coming to DKA, an absolute insulin deficiency as well as a counter regulatory hormone excess, they play a role in DKA. Okay, predominantly. Okay. So the counter regulatory hormone excess actually occurs in both conditions. Now let us see why this DKA develops. See, in DKA, I told you there is an absolute insulin deficiency, okay, often. And when there is an insulin deficiency, what happens is that we know there is hyperglycemia, increased blood glucose, correct? So blood glucose will be increased. But what is the problem? You know, you have a patient with hyperglycemia, so plenty of glucose is there in your blood. But can this glucose be utilized by your tissues? It cannot be. Because of the insulinopenia, the tissue utilization of glucose is not happening. So in spite of having a very high level of blood glucose, the body is not able to utilize that glucose. Correct. And what is the reason? Insulinopenia. So because the body is not able to utilize glucose as a fuel, what will happen? it has to depend on other sources for energy. And what is that other source? It will depend on the fats. So there will be increased lipolysis because of the increased activity of your hormone sensitive lipase. Hormone sensitive lipase activity will be increased. Okay, hormone sensitive lipase. So there will be increased lipolysis. So whenever there is an increased lipolysis, there will be increased level of free fatty acids. And from free fatty acids, what will happen is that you will have lot of production of your acetyl coenzyme A. Acetyl coenzyme A. Now when lots of acetyl coenzyme A is produced, in normal scenario, the acetyl coenzyme A will be diverted more to your TCA cycle. But the amount of the fatty acids, subsequently giving rise to acetyl coenzyme A. So acetyl coenzyme A is formed in so much amounts that these will be channeled to ketone body synthesis. This will be channeled to ketone body synthesis. Okay. So thus resulting in the formation of ketone bodies. And what are the major ketone bodies that are formed? You will have acetoacetate, acetone, and beta hydroxybutyrate. Okay, these are the major ketone bodies that are formed. Okay, so I hope you understood now how these ketones are actually formed in your diabetic ketoacidosis. Okay, and remember, these ketones, they are actually acidic. Okay, because the ketones are acidic, it will actually cause the ketoacidosis. Okay, it will decrease the alkali reserve and produce ketoacidosis. So that is how ketoacidosis occurs. And you know that these ketone bodies, they can cross the blood-brain barrier and they can damage the central nervous system, producing the various CNS manifestations. Okay, and because there is increased level of free fatty acids, your triacylglycerol, that is your triglyceride level, is also increased, leading to hyperglycemia. Okay, so one aspect of decay that you have seen is how the ketoacidosis sets in. Okay, that is very clear. Now let's see about the counter-regulatory hormones. You see, you know that we have discussed in a previous module that the level of counter-regulatory hormones actually increases when there is a demand. Okay, so but my question here is, see, the patient is having a hyperglycemic state. Okay, so if the patient is having a hyperglycemic state, why should the level of the counter-regulatory hormones be increased? Because what are the counter-regulatory hormones? You have the glucagon, you have the growth hormone, you have cortisol, and also you have the catecholamines. Okay, these are the counter-regulatory hormones. So the role of these counter-regulatory hormones is to increase the blood glucose level. So if there is hyperglycemia, why should there be an increase in counter-regulatory hormones? The answer is, see, though there is hyperglycemia, as I told earlier, the tissues are not able to utilize this glucose because of the insulinopenia. Okay, because of which, the tissues are not getting adequate, it is not coming into the cell, the glucose is not coming into the cell for utilization, because of which, as a compensatory mechanism, the level of counter-regulatory hormones will increase. And what happens as a result of the increase in counter-regulatory hormones? There is increased proteolysis and decreased protein synthesis, and subsequently, the amino acids will form gluconeogenic substrates, and there is increased gluconeogenesis, and subsequently it worsens the vicious cycle of hyperglycemia. So we started off with hyperglycemia, the counter-regulatory hormones are again contributing to hyperglycemia. So when there is a hyperglycemia, what happens is that there will be osmotic diuresis. Okay, the glucose will be excreted in urine. So there will be loss of water as well as electrolytes, leading to dehydration. Now this is very, very important. Okay, I want you to focus on this, the loss of water and electrolytes, because there is so much of a fluid shift and subsequent water loss that is happening. You keep this in mind, because when we are dealing with the management, this is a very, very important issue that we have got to address, that is your dehydration. So subsequently, dehydration can also result in impaired renal function. Okay, so I hope you understood that. Now, what happens is that because there is loss of water, electrolytes, there is increase in the osmolarity as well. Okay, there is increase in the osmolarity, but the increase in osmolarity is more pronounced in case of the hyperglycemic hyperosmolar state. So both in DKA as well as in HHS. So whether it be your DKA as well as HHS, you will have increase in osmolality. Okay, increase in osmolality. But in HHS, the increase in osmolality will be more marked. Okay, that is something you have got to keep in mind. Okay, so DKA, you understood the factors. Now what happens in case of HHS? You have a relative insulin deficiency more often. So there is absent or minimal ketogenesis. Okay, so that is one point that is differentiating your HHS from your DKA. In case of your DKA, you have ketoacidosis that sets in. There is lots of ketone body formation. But here, since there is a relative insulin deficiency and not a absolute insulin deficiency, you do not have ketone bodies. Okay, that is a major difference in the pathogenesis. This is what I wanted to show you. That is why, the comparison was shown on the pathogenesis of diabetic ketoacidosis and HHS. Yes, there are similarities, but again, you see this gross dissimilarity, don't you? The ketone bodies are not formed and there is no acidosis as well. But yes, something that is very marked is your hyperosmolarity. And whenever there is a hyperosmolarity, what can happen is that is not good for your brain, because always a hyperosmolar state will cause all these fluid shifts in your brain. So subsequently, it can cause damage to the brain. Okay, so it is the reason, it is because of these fluid shifts that you can have cerebral edema as a complication of your diabetic ketoacidosis as well as the hyperglycemic hyperosmolar state. And remember, the incidence of cerebral edema in DKA is more in children. Okay, it occurs more in children compared to adults, the cerebral edema. Okay, so I hope you have understood the basic pathogenesis of DKA and HHS, absolute insulin deficiency and increased counter-regulatory hormones in DKA, relative insulin deficiency and increased counter-regulatory hormones in HHS, no ketoacidosis in HHS, you have ketoacidosis in your DKA. So that is the basic difference in the pathogenesis. Okay, clear? This understanding is very important. Then only you will learn to manage. Okay, because if you know the basic difference between these disease processes, DKA and HHS, when it comes to actual patient scenarios, you would be able to make logical decisions also. Okay, all right. So now we will move on to a diabetic ketoacidosis. So as discussed, we will be now seeing diabetic ketoacidosis and subsequently we'll go with HHS. So diabetic ketoacidosis. See, for diabetic ketoacidosis to develop, it is very obvious that it develops in individuals who are having diabetes, goes without saying. So diabetic ketoacidosis to develop, which means they have got to be, in a diabetic patient, there must be some problem for this DKA to manifest. And these are what is called your triggers. Okay, your triggers of DKA. So triggers of DKA or the precipitating factors of DKA are the factors that would precipitate diabetic ketoacidosis in a diabetic individual. So what are the factors that would precipitate? Number one is poor compliance with insulin. Okay, suppose somebody is diagnosed with a case of diabetes, but he is not taking insulin properly. So if there is a poor compliance with insulin, what will happen? Naturally, there is an increased chance of developing a diabetic ketoacidosis. Second triggering factor is that this could be triggered by infections. So maybe some urinary tract infections or maybe some respiratory infections. So these infections can act as triggers for your diabetic ketoacidosis. Third factor is again your infarctions, either a cerebrovascular accidents or maybe an acute coronary syndrome, that is a myocardial infarction that is happening in an individual. This can act as triggers. Drugs like cocaine can act as triggers. Pregnancy is also a trigger for decay. Okay, so these are triggers for diabetic ketoacidosis. All right. So how will individuals present clinical features? We discussed regarding the triggers. So how will they present? So one feature is you will get nausea as well as vomiting. So all these ketone bodies, they would trigger the chemoreceptor trigger zone. They will activate the CTZ, and because it activates the chemoreceptor trigger zone, it can produce nausea and vomiting. Okay. Some individuals will have abdominal pain. Abdominal pain, sometimes the presentation may be almost like a acute abdomen also. Okay, acute abdomen. And I told you along with this you will have dehydration. So what the patient would be having is that patient may have features of dehydration. Okay, features of dehydration. Sometimes the dehydration may be so severe that the patient may land up in a hypovolemic shock itself. Okay, hypovolemic shock. Okay, so and sometimes the patient may be in altered sensorium, because I told you this ketone bodies can produce damage to your brain. So there can be altered sensorium, sometimes to the extent of a stupor or a coma. Okay, stupor or coma. So these are the presentations of your diabetic ketoacidosis. Okay, let's have a look at the table from Harrison on the manifestations of DK. You will have nausea, vomiting. Yes, thirst and polyuria like any diabetes, because there is loss of water loss also. So he'll be feeling thirst, abdominal pain, sometimes an acute abdomen, and sometimes there may also be a shortness of breath. Okay. Precipitating factors we have already seen: inadequate insulin administration, infections, infarctions, drugs, pregnancy. Now, what about the examination findings? So when you examine a patient with diabetic ketoacidosis, there is loss of fluid from the patient's body. Naturally, there will be tachycardia. Okay, sympathetic drive, there will be tachycardia, and dehydration. There is lots of fluids being lost in the urine. So you will have lots of dehydration and hypotension. It's very important. And always remember, in a patient in whom you suspect diabetic ketoacidosis, even if obviously you are not seeing hypotension at first look, just look for orthostatic hypotension also. Because if you take it lightly and if you say that, okay, the patient is not having any hypotension, and you ask the patient to walk, okay, then what happens is that he might develop a syncopal episode. So there is a chance of an orthostatic hypotension as well. Okay, because the fluid loss that happens in diabetic ketoacidosis, that is again plenty. And you will get tachypnea, and you will get Kussmaul breathing, which is your rapid acidotic breathing. Rapid acidotic breathing. And this is what is referred to as your Kussmaul's breathing. Kussmaul's breathing. And patient, sometimes may be presenting to you in emergency, sometimes as respiratory distress. So the presentation actually varies. It is not like every patient with DKA presents in a single way. Sometimes, the presentations, it might be a mild diabetic ketoacidosis, moderate or severe. So a severe diabetic ketoacidosis may be a patient who presents with tachypnea, shortness of breath, and he'll be having this Kussmaul breathing and hypovolemic shock. Okay, and the breath of the patient with diabetic ketoacidosis may be having a fruity odor. A fruity odor may be there. So the fruity odor is again because of your ketone body acetone. Okay, there may be a fruity odor to the breath. Okay, and abdominal tenderness is there. I told you it may mimic an acute pancreatitis or a surgical abdomen. Sometimes individuals with diabetic ketoacidosis may initially land up in the surgery casualty. Maybe they are having an acute abdomen. Okay, so this is again one important differential of an acute abdomen, Because in your exam also, when they frame a clinical scenario, they may frame a scenario of a patient who presents, a diabetic presenting with acute onset abdominal pain to the emergency department, and maybe in your ultrasound it is absolutely normal, and maybe your urine is showing ketone bodies. Remember, this could be a diabetic ketoacidosis. And I told you there can be central nervous system manifestation also, which can vary from a mild altered sensorium to a stupor or coma. So these are the spectrum of manifestations that you expect in case of a diabetic ketoacidosis. Okay, so I hope you understood how the patient is going to present to you. Okay, now suppose the patient has come to you in the emergency, and how will you diagnose? You have understood the clinical features, and how will you diagnose? History is very important. A diabetic patient may be triggered by inadequate intake of insulin or maybe some infections. Most often, there will be some trigger for your DKA, and it is important that you treat the DKA as well as treat the trigger. That is very important. Okay. So what about the investigations? See, whenever you check the blood glucose of the patient, you check a random blood glucose at the time of presentation, you will find that the value is very high. Remember, DKA always develops only if the blood glucose is above 250. Most often the sugar will be above 300, 350, but at least 250 level is required to produce a diabetic ketoacidosis, which means you are unlikely to have a patient who develops a DKA at a blood sugar level of 220. Okay, so the blood sugar will be high. And what about the urine ketone bodies? Okay, urine ketone bodies. So you can go for the urine ketone body test. I'm sure that you remember the Rothera test for your ketone body estimation. So urine ketone body test will show ketone bodies. But remember, I told you there are 3 ketone bodies, and out of the 3 ketone bodies, it is usually the acetoacetate which is often that is detected by this urine ketone body test. Which means, suppose if the individual is having a beta hydroxybutyrate, sometimes may not be detected in a patient when you do the urine ketone body. So just because urine ketone body is negative, you cannot completely rule out diabetic ketoacidosis. Because to estimate your beta hydroxybutyrate, you need to go for other tests like estimation of your plasma beta hydroxybutyrate. So you will have to go for the plasma levels. But again, the availability of plasma beta hydroxybutyrate is not so good in the settings unless you are in a center where you have an estimation of plasma beta hydroxybutyrate. So urine ketone bodies you can check, and then you have got to understand that the osmolality, the plasma osmolality will definitely be high. Okay, so the plasma osmolality will be high. So it will not be as high as in your HHS, but still you will have in the range of maybe 300 to 320, 325 milliosmol per kilogram. Okay, so the plasma osmolality will be high. Okay, and it is very important to note that you will have abnormality in the electrolytes. For example, in case of DKA, you will get hyponatremia, and the type of hyponatremia that you get in DKA is called because since the osmolality is high, it is called a hypertonic hyponatremia. Okay, hypertonic hyponatremia. And what about the potassium levels? See, the potassium levels, what happens is that since the patient is having an acidosis, okay, remember the acidosis is there. So whenever there is acidosis, that will cause a redistribution of the body potassium, so that the potassium which is predominantly an intracellular cation, this would come to the extracellular space, and so you will have a hyperkalemia. Okay, hyperkalemia, and also your phosphate levels also will be high. You will get a hyperphosphatemia. Okay, so these are the electrolyte abnormalities that you can expect. And then what about your levels of your ABG when you do a ABG in a patient? Because this is ABG is definitely mandatory in a patient with diabetic ketoacidosis. So remember, it is acidosis, so pH will be low. And since the patient is having Kussmaul breathing, rapid acidotic breathing, There will be a carbon dioxide washout. The CO2 washout will be there, because of which the PCO2 also will be reduced. The bicarbonate levels, again the ketone bodies, they are producing acidosis. So all these bicarbonates will be consumed, and the bicarbonate levels also will be reduced. So this is the picture that you would expect in a case of in the ABG of a patient with a clinically suspected diabetic ketoacidosis. All right, that's about the ABG. Okay, so these are the investigation findings that you will get in a patient with diabetic ketoacidosis. But always remember, do look at the total WBC count, because I told you one of the triggers for diabetic ketoacidosis is infection. So sometimes you may miss, since it is an emergency, you may miss the actual problem. Patient may be having a pneumonia. So the total count may be high, and when you take a chest x-ray, you might be seeing consolidation. So you check the WBC count also. And it is important to check the renal function test also, because there is so much of dehydration that is happening, fluid loss that is happening. So initially there can be an acute kidney injury, a pre-renal injury can be there, and subsequently maybe it can cause a renal injury as well. So to begin with, you always check the blood total count as well as your renal function test as well. Okay, this is very, very important. All right. So we have understood how to evaluate a patient with diabetic ketoacidosis and to make a diagnosis of diabetic ketoacidosis. Now, once you have made a diabetic ketoacidosis diagnosis, let's come to the treatment part. So I'm sure that each one of you would agree with me, this is definitely another endocrine emergency, correct? So it has to be managed aggressively and at a good pace as well. Okay, so it is not something that can be managed with a calm, relaxed environment. I'm not saying you should be anxious or you should be running around, but the moment you diagnose DKA, you understand that okay, time is important. Okay, so do not waste time, because see, if you waste time, what will happen is that there is always a possibility of complications setting in. And these complications are more commonly seen in the elderly individuals who already have other comorbidities. Okay, maybe associated coronary artery disease. So especially if you are dealing with someone who has an underlying comorbidity like a coronary artery disease, the management again has to be very stringent and you have to be very careful. Okay, so let's see the management part. See, coming to the management part, though diabetic ketoacidosis, you might think that, okay, there is a high blood sugar, so I should bring down the blood sugar. You are absolutely right. But if you are asked what is the cornerstone of management, it's fluid replacement. Okay, so fluid replacement is the cornerstone of management of diabetic ketoacidosis. Very important. So why do I say this is because, see, in a diabetic ketoacidosis, I told you it can be mild, moderate or severe. But in an average, you would have at least a fluid loss of around 6 liters. Okay. And out of these 6 liters, maybe around 3 liters of ECF as well as 3 liters of your ICF would have been lost. Okay. So almost, on an average that you can say 6 liters loss is there. Sometimes in a severe decay, it can be more. Okay. It can be 8 liters like that. So there is a lot of fluid loss happening here. So the fluid replacement is of paramount importance. Okay. Because otherwise, I told you the patient can land up in a hypovolemic shock. Okay. You don't want that to happen. So please always first fluids. And what is the fluid of choice? You will always go for a normal saline. Normal saline is the one that is always that is preferred. What about other fluids? Can you use fluids like ringer lactate? See, it is no contraindication, but we generally do not prefer a fluid like ringer lactate in diabetic ketoacidosis. The problem is that, ringer lactate would itself have good potassium content. And remember when I discussed about the electrolytes, I told you there is hyperkalemia that can happen. So you do not want to have a fluid that is again going to increase your potassium. So preferred fluid is always your normal saline. Okay. So let's now see how the fluid is given. First and foremost, remember that you have to have aggressive fluid replacement. So it is not like you put a normal saline slow drip and then you go away. So it has to be an aggressive fluid replacement. Now, exception is there. Suppose if the patient is having an underlying coronary artery disease, he's already had say 2 attacks of a myocardial infarction and anterior wall MI. In such a patient, you have to have a judicious fluid replacement. Okay, it has to be under supervision, and again, you cannot be too aggressive. But otherwise, in any other individual, you will go for a aggressive fluid replacement. And let's see how fast the fluid is being replaced. See, there is no definite single consensus guideline, though there are different proposed guidelines. You do not have a single accepted guideline for the fluid replacement. But I'll just give you an overall idea on the fluid replacement. So very important is to assess the volume status. I already told you it can be a mild, moderate or severe. So when you see the patient itself, suppose you are seeing the patient in the casualty and you are seeing that the oral mucosa of the patient is very dry, it's itself giving you an indication, okay, he's very much volume depleted. And you check the blood pressure is very low, is again giving you an indication he is too much volume depleted. Okay, so that is very important. So it can be a severe hypovolemia, mild hypovolemia, or sometimes in a cardiogenic shock. Okay, so the fluid replacement has to be accordingly. Now remember that you usually start off with your normal saline, and when you start off with your normal saline, you start the administration at around 1 liter per hour. Okay, 1 liter per hour, and that is given especially in the initial hours. For example, in the initial 3 hours, you would give around 3 liters. Okay, 3 liters in initial 3 hours. Remember, be careful if the patient is having a heart disease. Okay, otherwise 3 liters in 3 hours, you are giving it as a infusion, normal saline infusion. And then what you do is that it is very important that while you give your fluids, it is important to check your electrolytes as well. Why do I say this? Because see, electrolytes, when you supplement fluids, there can be change in the electrolyte levels as well. So just because at admission the sodium level of the patient is 124 milliequivalents per liter, doesn't mean that after starting fluid replacement and through the subsequent course, the sodium will be like that. It will keep on changing. So which is why you have got to check your sodium levels, electrolytes like sodium, potassium, phosphorus, all these should be actually checked periodically. Ideally, 2 hourly at least you should check them. So when you check these levels, suppose, I told you in DK you expect hyponatremia. But once you are replacing the fluids, what will happen is that the sodium levels can increase to the tune that patient may go for a hypernatremia, higher sodium value. So periodically check your sodium values. And if the sodium value is normal, or if the sodium value is still low, in that scenario, you can continue infusion with your normal saline. Okay. But after the initial 3 hours, you can think of reducing the infusion rate, because previously you were giving at a rate of 1 liter per hour. Now you can reduce the rate to around 250 to 500 ml per hour. But remember, normal saline can itself be used provided the sodium level is on the lower side. Now, what if the sodium level has normalized, or when you are checking you find the sodium level is increased? Will you continue with normal saline? The answer is no. Because if you continue with normal saline, you are likely to produce hypernatremia. And you know that hypernatremia is also not good for your brain. So you do not want hypernatremia to develop. In that case, if the sodium is either has normalized or it is high, you will change your fluid to half normal saline. Yes, the infusion rate will be the same, 250 to 500 ml per hour, but the vehicle will be a half normal saline so as to prevent hypernatremia. Okay, all right. So remember, you then continue the infusion. But once the blood glucose level, because we are constantly checking the blood glucose level, Okay, every half hour, you monitor the blood glucose level. So if the blood glucose level, you can even monitor in a patient in whom it is the blood sugar level is very high and you're going for a very aggressive management. Even, more frequently also you can measure the blood glucose level. But once the blood glucose level has reached the mark of around 200 milligram percentage, then what happens is, till this time you were giving normal saline or half normal saline, you will change the vehicle to 5% dextrose. You will change the vehicle of administration to 5% dextrose. Now, why did we change it from a normal saline to a dextrose? I'll tell you the reason. The reason is because I told you in a DKA, even if it is a mild to moderate DKA, you will have around 6 liters of fluid loss. I told you 3 liters is the extracellular fluid loss and 3 liters is the intracellular fluid loss. Your first aim should be to replace the extracellular fluid loss. Okay, it is for that you are giving your normal saline. But you have got to replace your intracellular fluid as well. So if you want to replace your intracellular fluid, you have got to give something like a 5% dextrose. Because when you give your 5% dextrose, see, the sugar moiety will be utilized, and after that the water is there. This water is a hypotonic one, so it will enter inside the cell. Okay, so it will help to replace the intracellular fluid ICF loss as well. Okay, so that is important. All right, so then that time you are giving 5% dextrose, and also it has another advantage that it will prevent hypoglycemia from developing, because already the sugar has reached 200. Okay, so and then you change to 5% dextrose. But if you ask me, are you completely going to stop your normal saline? See, if the patient, you at the time of clinical assessment, you feel that he looks still dehydrated, you can continue maybe your half normal saline, okay, at this 250 ml per hour rate. Okay, so that can be continued. So this is how you would manage the fluid status in a patient with diabetes, diabetic ketoacidosis. Remember, this is the cornerstone of management. The fluid replacement is the cornerstone of management of DKA. Number 2 is about insulin replacement. Okay, what about insulin treatment? So yes, insulin treatment also has to be given, no doubt about it. So how do you give insulin in a patient with diabetic ketoacidosis? First, you will give a bolus dose, and that bolus dose will be 0.1 units per kg. You will give as bolus dose, and this is followed by an infusion, insulin infusion, and this insulin infusion will be given at a dose of 0.1 units per kg per hour. So you are giving an insulin infusion also. Okay, because why don't you just go for some subcutaneous insulin dosage? See, problem is, you will not be able to give a steady supply of insulin when you are just giving some subcutaneous doses. Though some guidelines say that if it is a mild DKA, instead of going for an infusion, you can go for the subcutaneous short-acting dose. But in an ideal scenario, it's always good that you go for an infusion. And what is the insulin preparation that you will use for the infusion? Remember, the insulin that can be given intravenously, we have discussed this. This is going to be your regular insulin. So it is your regular insulin or plain insulin that you are going to give by an infusion. Okay, and periodically you have to check your blood glucose levels as well. Okay, now coming to the insulin therapy. So I told you you have two options to go for the intravenous route or the subcutaneous route, but what is preferred? It's always a IV infusion that is preferred. So I told you about the bolus dose as well as the continuous infusion. Now I told you have got to monitor the blood glucose levels. Now if in the first hour after instituting an infusion of your insulin, if it does not fall by, because you expect it to fall by at least around 50 milligram percentage, 50 milligram per deciliter. Suppose if it does not fall to the tune of 50 to 70, in that case you give double the bolus dose, because initially you gave it as a 0.1 units per kg as bolus. In that case, you give 0.2 units per kilogram. So double the bolus dose is given, because the response to therapy in patients with diabetic ketoacidosis is different for different individuals. See, it would depend on various factors like what exactly was the triggering factor, what is the status of the insulin resistance in the patient. It would depend on a lot of factors. So you give the double the dose of bolus if it does not fall to around 50 to 70 in the first hour. Because remember, in the first hour, expect only that much decrease. You're not expecting a decrease up to say 200 in the first hour. Okay. All right. So then, that is why, remember one thing also, you might ask me a question, sir, why this infusion? Why can't you just give a high bolus dose? You keep on giving some bolus dose of insulin rather than this infusion and drastically bring it down. See, you cannot be over aggressive while you treat hyperglycemia, because then that would result in lot of fluid shifts and lot of electrolyte problems as well. Because see, when you supplement insulin, you know that insulin is one hormone that will cause redistribution of your potassium. So when you give insulin, the potassium will go inside the cells, and what will happen? The patient would develop hypokalemia. So if you are not giving in a titrated manner, you are just giving, keeping on giving bolus doses. What if the patient actually develops a hypokalemia and, he might develop a cardiac arrest? So you do not want that to happen. And because of which, you would always prefer an infusion. Also, too rapid blood glucose changes would actually produce a fluid shift as well. So you do not want abrupt fluid shifts. So you will go according to an infusion. Now, when you go according to an infusion and suppose the blood glucose reaches 200, okay, so you have gone with an insulin infusion at a 0.1 unit per kg per hour, and the blood glucose has reached around 200 milligram per deciliter. In that case, you can reduce the insulin infusion dose to around 0.05 units per kg per hour. Sometimes even 0.02 also, but in general, you go for half the infusion rate. Why do you half it? Because otherwise the patient may develop hypoglycemia. Why don't you stop it? Patient has reached 200. What is the need of further insulin? Remember, the patient has just developed an emergency. If you abruptly stop the insulin, what will happen? The patient would again, there will be a rebound hyperglycemia and he might again go to decay. So don't think that once you reach a safe blood glucose level, all is done and you can go back, the blood glucose has reached. It's not like, it's like, you're hitting somebody and he falls on the floor, but make sure that he doesn't get up, okay? Because if he gets up, he is going to punch you back again. So always remember, once it reaches 200, further reduce the rate of insulin infusion. And it's always important to check periodically your electrolytes, your renal function test, your arterial blood gas, ABG also. And then what happens is that once the patient is able to take oral feeds, you can shift to subcutaneous insulin. Okay, you can shift to subcutaneous insulin. If the patient is in a state of altered sensorium, you would go with an insulin infusion itself, which can be further down titrated, because you do not want to give a subcutaneous insulin in a patient who is in altered sensorium. You want to always titrate, so it should be under your control. So only if the patient is in a stage like, he's conscious, he's alert, he can take feeds, then you go for your subcutaneous insulin. But now another very, very important point that you have got to keep. Many of the times, residents, may make a mistake. It's like they might bring down the sugar beautifully to a value of around, say, under 200. So you might see that the patient is having, is fully conscious. So then you might think, okay, now let me change over to my subcutaneous form. So he'll stop the insulin infusion and then abruptly start the subcutaneous form. What is the problem? See, you have already learned in pharmacology that as well as, in the module where I've discussed insulin, also I've told that for a plain insulin to start action, it would take around 30 to 45 minutes. Correct, no? So suppose you are stopping the insulin infusion now and you are giving the patient subcutaneous insulin. it would take another 30 to 45 minutes for the action of subcutaneous insulin to set in. So during that period of 30 to 45 minutes, there is a good chance of a rebound and a fight back by your blood glucose levels. So please do not abruptly stop your infusion and start your subcutaneous. Always remember there should be an overlap between your infusion and subcutaneous. So the duration of the overlap at least should be around an hour. Okay, but ideally you say that 2 hours or sometimes even 4 hours may be needed. Again, that depends on your monitoring as well. But again, at least 1 hour of overlap should be there, at least. Okay, preferred is the 2-hour overlap. Okay, so don't make this mistake. Okay, so this is how you will down titrate your insulin requirement in diabetes. I hope that is very, very clear. So second point is the insulin management. Third point is managing your potassium levels. Now, why have I discussed this separately, the potassium levels? Now, this is very, very important because I told you there is fluid replacement, there is insulin, and I already told you when you give insulin, there is a chance that your potassium may redistribute inside your cell, and there is a chance that the patient may develop hypokalemia. Okay, and you know that hypokalemia is not something that you want. Now, this is why periodic monitoring of electrolytes is important. Okay, I told you in between, you have to monitor the electrolytes as well. Otherwise, what will happen is disastrous complications. So just let's see, how potassium is monitored. See, when you go for potassium monitoring, okay, so if the potassium, I already told you, you expect some sort of a hyperkalemia in your in DKA. So in between, when you periodically check, when you see the potassium is on the higher side itself, then there is no need for any potassium supplementation. Okay, you must be careful that the patient does not go for a hyperkalemia. Okay, so if the value is more than 5.5, you should be very vigilant and you should give, think of giving anti-hyperkalemic measures. But again, if the potassium is in and around the 5 range, okay. But if the value is 3.3 to 5.3, it's almost in the normal range. But remember, you are continuously giving insulin. Okay, so there is always a chance that the patient can go for a hypokalemia. So in that case, it is it is advised that you can actually give some potassium supplementation. You can give your KCl supplementation. Okay, so you are giving your around 20 to 30 milliequivalents of potassium in each liter of IV fluid, and your target is to maintain the potassium level in the 4 to 5 range. Okay, now this is very, very important. So I told you DKA management is highly skillful, because it is not just about monitoring one entity. It's just not about monitoring your insulin infusion. You have to monitor your fluid status, how is the blood sugar level, how is your potassium, how is your sodium, how is your ABG levels. So your eye should be on everything, which is why I told you it's an emergency. It has to be managed aggressively as well. So I hope you understood that. Now, what if the potassium at one point of time, you see it is around say 2.6. Okay, suppose you are managing a DKA patient and you are giving insulin, you are giving insulin infusion. You see that at one point of time, your potassium level is 2.6. Remember, stop your insulin infusion temporarily. Temporarily, you hold the insulin and you supplement potassium 20 to 40 milliequivalents per hour until it is above your 3.3 or maybe your 3.5 milliequivalents per liter. In that case, only once it has reached the normal range, you resume your the insulin infusion. Now, this is very, very important. Okay, because hypokalemia is such a dangerous complication, you do not want that to develop. Okay, so I hope that potassium correction is also clear. Okay, now what about the next one, that is your bicarb? Okay, what about bicarbonate? Should you supplement bicarbonate because this is diabetic ketoacidosis? So what about giving some bicarbonate? Remember, usual scenario, diabetic ketoacidosis, we give bicarbonate only and only when the pH is less than 7. only if the pH is less than 7, you will give the patient bicarbonate. Okay. So the problem is, otherwise what will happen is that if you give bicarbonate, so you know that this bicarbonate is going to produce alkalosis. So if alkalosis sets in, what happens to the potassium level? You will again develop a hypokalemia. I told you we do not want hypokalemia to develop. We are so concerned about that. So we are concerned about alkalosis developing. So pH less than 7, only in that scenario you will give a bicarbonate supplementation. In that scenario only you will give a bicarbonate supplementation. And also remember one fact, once the pH goes above your 7.1 range, you will stop bicarbonate. Okay. So your role of bicarbonate is only to get your pH above 7. Okay. So only if there is acidosis, please do give your bicarbonate. Okay. All right. So regarding electrolytes, I have told you. Next point is treating the actual infection. So treating the trigger. So remember I told you the trigger can be an infection, a trigger can be a stroke, trigger can be a myocardial infarction. All these can be triggers. So please make it a point that you take ECG also of the patient, because the patient might be brought with tachypnea, Kussmaul breathing, and he might be having hypovolemia. But only when you take an ECG, sometimes you might see that the patient has developed a myocardial infarction. Probably he might not even give a history of chest pain because the patient is a diabetic. He might have had a silent attack. So always remember, go for the ECG and also check whether the patient is moving all limbs. Okay, whether there is a focal deficit. So you look whether there is any trigger. And also if there is a trigger like an infection, you have to aggressively treat the infection, because that is very important. Because if the patient is having a pneumonia, and if you don't treat the pneumonia, however hard you try to manage your decay, again there is going to be a rebound, because the actual inciting factor is still there. So it is very important that you address the trigger also. Okay, and that is how you will manage diabetic ketoacidosis. And if the patient has developed this decay because of his poor complaints at the time of discharge, you have to advise the patient again that, see, this is an episode of decay that has developed only and only because you have stopped your insulin. So adhere to your medications, which is an advice that you have got to give to the patient. Okay. All right. So you have understood regarding the management of diabetic ketoacidosis. Now let's see regarding the next entity, that is your HHS or your HONK. Okay. So let's see that. Hyperglycemic hyperosmolar state or hyperosmolar non-ketotic coma. So we've already understood how this develops. Okay, so let's see how it is different from your diabetic ketoacidosis. So remember, first and foremost, there is no ketoacidosis. That is the first and foremost point that you have got to understand. So it is definitely a hyperglycemic hyperosmolar state. So most of the damage actually occurs because of your hyperosmolality. Okay, hyperosmolality. So the hyperosmolality is the one that actually causes all these problems, your central nervous system manifestation, because sometimes the patient actually may be brought in a stupor or a coma. Okay, again the manifestation of a hyperosmolar state. So remember that when a patient with a diabetes is brought to you with an altered sensorium, it can either be a diabetic ketoacidosis or it can be a hyperosmolar coma. So how will you differentiate it? Remember, when you do the ABG, in case of your hyperglycemic hyperosmolar state, your pH would be normal. Okay, your PCO2 will be normal. Okay, and your bicarbonate will be normal. So there is no ketoacidosis that is happening here. So your ABG will be perfectly normal, and when you check your urine ketone body and the urine ketone body, it is nil. Okay, You know that such a scenario can happen in a diabetic ketoacidosis, but again, the ABG is absolutely normal. Okay. So unless the patient probably has developed another complication, maybe the patient with a hyperglycemic HHS may also develop an associated lactic acidosis. Okay, he may develop a lactic acidosis. So in such a scenario, the pH may be low. But here again, you would not have any other findings, like you would not have a urine ketone bodies positivity. So remember, a lactic acidosis can develop as a complication of your HHS also. But in otherwise, your ABG is normal. Okay. So that's about your HHS, how it will present. Remember all the manifestations with hyperosmolality. And you can have, altered sensorium, and one major important presenting feature is your severe dehydration. Severe dehydration. And remember, the dehydration is often more than your diabetic ketoacidosis. And the patient may go for a hypovolemic shock. The patient may go for a hypovolemic shock. Okay. So you have to keep in mind these factors about HHS. Okay. Now, the management of HHS again is slightly similar to your diabetic ketoacidosis, because the most important cornerstone management is your fluid replacement. Yes, you have to supplement the patient with insulin as well. You have to monitor the electrolytes, even though you are not having any acidosis per se. Because you are giving insulin, you might have your changes in your potassium. Okay. So these are the factors that you have got to keep while managing a patient with HHS. Okay, very important. I hope that is very clear. So now let's move on to a table where we are trying to compare your HHS as well as your DKA. This is from Harrison. See, one point that you have got to understand is the amount of hyperglycemia will be more in case of your HHS compared to your DKA. So DKA definitely it will be high, 250 to 600. So HHS, can be further high. You see 600 to 1200. But just because a blood sugar value is 550, you cannot say that, okay, this is 100% DKA. You cannot say that, because it could be an HHS also. So it is just that this is providing you a rough guide that very high values are expected in a HHS. Hyponatremia, as I told you earlier, is a feature that is expected in a DKA. In a HHS, usually the sodium levels are normal. The potassium levels, I told you, it is normal to slightly increased. And I told you what is the reason. It is the acidosis that is causing the hyperkalemia. But since there is no acidosis here, it is normal in case of HHS. The magnesium and chloride levels and phosphate levels. Remember, magnesium and chloride levels are normal in both. Phosphate, remember, DKA can be normal, but I told you it can be increased also. Okay. So it is actually normal to increased. Okay. Whereas in HHS, it is normal. And creatinine, it is slightly increased in case of your DKA and moderately in case of your HHS. The basic reason being more dehydration and a more chance of an acute kidney injury is with your HHS compared to your DKA. In fact, the mortality of your HHS is also more compared to your DKA. See the osmolality range. I told you 300 to 320 is the osmolality range in DKA. But remember, when we discussed the pathogenesis, I told you the hyperosmolality is more pronounced in HHS. So it is 330 to 380 in your HHS. The plasma ketone bodies you can see in your DKA. Okay, not in your HHS. The bicarbonate levels, it will be decreased in your DKA, whereas normal to slightly decrease in your HHS. Because why it is decreased in your DKA? Because of your ketone bodies producing an acidotic state. But HHS, you can just think that it is more or less normal. The pH, it can vary from 6.8 to 7.3, meaning that there may be acidosis, there may not be acidosis, but usually the severity of acidosis, it's not like there is acidosis, but the severity can vary. It may be a mild acidosis, it may be a severe acidosis. So, whereas in HHS, you are not expecting the acidosis. The PCO2, I already told you, there is a Kussmaul breathing in your DKA, there is carbon dioxide washout. So, there will be PCO2, the normal value is around 40. So, you expect in the range of 20 to 30 only. HSS is relatively normal. And remember the anion gap diabetic ketoacidosis, it is high, whereas so it is a high anion gap metabolic acidosis that happens in your DKA. In your HHS, it may be normal to slightly high. Okay, so these are the important differences between your diabetic ketoacidosis and HHS. So I hope you have conceptually understood the management of these two entities. So remember, you have got to have a good grip on this management. And remember, nobody can teach you a single flowchart that you can apply to every patient. I told you, whether it be your fluids, your insulin or your electrolyte management, certain decisions are taken at that moment. Okay, because I told you the insulin infusion, the rate that you give will also depend on your potassium values. So it is not like you study one flowchart and just apply to each and every patient you see. It's not like that. See, guidelines are always to guide clinicians, but certain decisions, we should take logically and based on common sense. Okay.